Hello, this is Dr. John Mascarenhas from the Tisch Cancer Institute, the Icahn School of Medicine at Mount Sinai in New York City. Welcome to this educational program that will explore how physicians and patients can work together to manage polycythemia vera, including inadequately controlled disease. In the second part of this program, I'll welcome a patient with polycythemia vera, Joanne Menino, into a discussion of these topics. Now, let's begin by looking at PV and the problem of uncontrolled disease.
The following audio is part of a certified educational activity titled Meeting the Many Challenges of Uncontrolled PV, How Physicians and Patients Can Work Together to Optimize the Therapeutic Journey. Access the entire activity and complete the post-test at www.peerreviewpress.com/MBS. Downloadable slides and practice aids are also available.
Polycythemia vera is a chronic myeloproliferative neoplasm characterized by overactivity of the Janus kinase signal transducer and activator of transcription, JAK-STAT pathway, through mutations in JAK2 exons 12 or 14, such as the JAK2 V617F mutations. PV is also the most prevalent of all MPNs, with an incidence of about 1.8 to 2.8 per 100,000 patients. It has a slight male predilection, and most patients tend to be greater than 60 years of age. The dominant clinical characteristics include erythrocytosis, with or without leukocytosis and thrombocytosis, thrombotic events, hemorrhagic events, and various constitutional symptoms. These symptoms may vary and can include fatigue, pruritus, and weight loss, among others, as is shown on this slide. Symptoms in PV can be additionally categorized as cytokine-related symptoms, vascular-related symptoms, or disease evolution-related symptoms like splenomegaly and constitutional symptoms. These symptoms can be present at the time of diagnosis and throughout the disease course and can worsen over time. Certain symptoms may also require additional vigilance at specific times during the disease course. For example, initially, thrombosis may be our greatest concern, whereas in the second decade, post-diagnosis, we begin to focus more on preventing disease progression and transformation. What about PV diagnosis? Well, the WHO has published diagnostic guidelines for PV, and these guidelines were recently updated based in part on a modern understanding of PV and its features of presentation. According to the new guidelines, 3 major criteria are required for a diagnosis. These include evidence of erythrocytosis, which may be either an elevated hemoglobin or hematocrit, or more traditionally, an elevated red cell mass, the presence of a JAK2 mutation in either exon 12 or exon 14, and the presence of characteristic bone marrow trephine features with hypercellular marrow, trilineage proliferation, and megakaryocyte abnormalities. In the absence of the third of these 3 major criteria, the presence of reduced serum erythropoietin level is then adequate to make a diagnosis of PV, according to the WHO. Note that the hemoglobin threshold in the updated 2016 criteria has been reduced to 16.5 grams per deciliter in a man and 16 grams per deciliter in a woman to capture a subset of PV patients that have been labeled masked polycythemia vera and previously would not be appropriately captured by the diagnostic criteria. Given the more immediate and longer-term consequences of PV for patients, which, as we've seen, can include thrombosis and bleeding, and transformation to myelofibrosis or leukemia, respectively, the general goals of therapy in PV are to reduce the thrombosis rate and delay disease transformation. Many of us, I think, are familiar with the simple thrombotic risk stratification shown on this slide. Low-risk patients lack a history of prior thrombosis and are typically less than 60 years of age, whereas high-risk patients have either a history of thrombosis or are now advanced in age beyond 60. Also, cardiovascular factors are sometimes considered a risk factor worth incorporating into the stratification tool and can capture a patient population that's deemed intermediate risk. Recently, a newer risk assessment model has been proposed by colleagues from Italy and the Mayo Clinic using a retrospective analysis from several centers of excellence over 1,500 patients. In this analysis, 4 key risk factors were identified by multivariable analyses, with age over 67 years having a score of 5 points, age between 57 and 66, 2 points, and leukocytosis of greater than 15,000 per liter, 1 point, and the presence of venous thrombosis, 1 point. Using this system, these authors were able to identify 3 different groups of patients with highly varying median survivals. For example, low-risk patients who have none of those factors have a median survival of approximately 27 years, and the high-risk patients who have at least a score of 3 have a median survival of 10.8 years. This risk scoring system has not yet been included in routine practice, but it does show that some additional factors beyond thrombosis and age, such as leukocytosis, may be relevant for risk modeling. Let's turn to risk-adapted management of polycythemia vera. In general, I think that addressing modifiable cardiovascular risk factors is an important starting point for all patients. A mainstay of therapy for all patients, but particularly for patients with low-risk disease, is the use of phlebotomy, often accompanied with an antiplatelet agent, most commonly aspirin, at a dose of 81 milligrams per day. Therapeutic phlebotomy to a hematocrit target of less than 45% has been standard practice in the U.S. for some time, and we will look at the data that supports this shortly. Currently, options for first-line cytoreductive therapy are mainly either hydroxyurea or interferon, although agents such as busulfan may in some cases be useful. Recent years have also witnessed the approval of the JAK2 inhibitor Ruxolitinib for patients who have hydroxyurea refractory PV, which we will also discuss in more detail shortly. A moment ago, I mentioned that treating to a target hematocrit of 45% or less than 45% was an important feature of PV therapy. We have a good deal of evidence that shows why this is so important. In essence, we know that treating to this threshold allows us to successfully achieve one of the goals of therapy, the reduction of thrombotic events. This was convincingly shown in the CYTO-PV study, in which treating to target hematocrit reduced the rate of major thrombosis and death from cardiovascular events by a factor of 4. We'll return to CYTO-PV shortly, but now I'd like to shift the discussion and describe what can happen when therapeutic goals are not met in the PV setting. As I mentioned earlier, a mainstay of therapy for all patients, but particularly for patients with low-risk disease, is the use of phlebotomy in conjunction with low-dose aspirin. However, lack of response to phlebotomy can often manifest in several ways, including in persistently elevated hematocrit or the need for frequent, difficult-to-manage phlebotomies. Other signals may include progressive leukocytosis or thrombocytosis, a thrombotic event, progressive symptoms, or splenomegaly. This can be described as inadequately controlled or uncontrolled polycythemia vera and can occur at any phase of the disease and may result in reduced survival. We've seen how important controlling the hematocrit is in PV, but it's also important to note that persistent leukocytosis is associated with the risk of thrombosis and has also been linked to leukemic transformation and shorter survival, whereas lack of a platelet response or persistent thrombocytosis is particularly associated with risk of thrombosis and bleeding. Indeed, in the CYTO-PV study, a recent analysis showed that leukocytosis of at least 11 or greater was associated with increased risk of thrombosis alone. It's important to be aware of these events because they may signal a need for more aggressive therapy in patients who previously may have experienced disease control with phlebotomy alone. Now, let's turn to some possible options for managing patients with whom phlebotomy alone is no longer adequate. For these patients, who still require control of symptoms, blood counts, or spleen size, high-risk disease may be present. As noted earlier, cytoreduction, usually through the use of hydroxyurea, is a standard first-line treatment option in PV. The European Leukemia Net Guidelines, the ELN, recommend cytoreduction for all high-risk patients, but also for specific low-risk patients. These include patients with frequent phlebotomy requirements, uncontrolled significant disease-related symptoms, a platelet count in excess of 1,500, which are associated with an increased risk of bleeding, or progressive leukocytosis. Now, let's look at the first-line options for high-risk PV and discuss some clinical considerations with these agents. Hydroxyurea can be clinically efficacious and may be used to manage splenomegaly and control blood counts. Typically, doses of 1 to 2 grams per day are used, depending on the patient or response to therapy. Although there's been some suggestion that hydroxyurea therapy, particularly long-term therapy, is leukemogenic, to date, most evidence does not support this conclusion. Interferon may be considered a second-line option in PV post-hydroxyurea therapy, but also as an alternative upfront therapy in patients who are unlikely to benefit from hydroxyurea. In particular, I think of interferon as a feasible initial option in younger patients with high-risk PV or in those whom we would be reluctant to use hydroxyurea. There are, of course, several safety considerations that should be noted with interferon, including flu-like syndrome, depression, anxiety, and mood lability, and the potential for autoimmune diseases. And in older patients, we would not consider interferon as our initial choice due to the potential for increased toxicity and reduced tolerability. We do have some recent interim phase 3 evidence on pegylated interferon as an initial option in polycythemia vera. In the MPDRC 112 trial, 168 patients with high-risk PV or essential thrombocythemia that had been diagnosed in the last 5 years were randomized to pegylated interferon alpha 2A, weekly injections, or hydroxyurea. So when looking at the results of the interim analysis of the MPDRC 112 as presented at the American Society Hematology meeting in 2016, one could appreciate that the complete response rate at 12 months of therapy in the hydroxyurea arm was 33% versus 28% in the pegylated interferon alpha 2A arm. This was a not statistically significant p-value of 0.6. However, if you look at the overall response rate of 69% with hydroxyurea therapy versus 81% with pegylated interferon therapy, there appears to be an advantage that's driven primarily by increased partial responses with pegylated interferon. Most people in this field would agree that these results are likely too early to be conclusive. We need further follow-up and longer-term follow-up, which will be presented in the final results of this important pivotal phase 3 study, likely the first or second quarter of 2018. Now, let's turn to treatment choices for when cytoreduction is no longer effective. Some patients on hydroxyurea may not receive adequate benefit or may not tolerate long-term therapy. One study by Alvarez-Laran and colleagues found that 12 and 13% of patients with PV had resistance and intolerance to hydroxyurea, respectively, with the former significantly associated with an increased risk of death. This initial pivotal analysis conducted from the data gathered from Spanish centers demonstrated that lack of white blood cell normalization and meeting the definition of hydroxyurea resistance was associated with worse outcome in PV patients. In a follow-up paper including more patients, the same investigators demonstrated that the development of cytopenias on hydroxyurea therapy, rather than meeting the combined resistance and tolerance definition, was associated with worse survival and an increased risk of transformation to acute myeloid leukemia. Lastly, they also showed that the continued need for 3 or more therapeutic phlebotomies on maximally tolerated dose of hydroxyurea was associated with increased risk of progression to myelofibrosis and evolution to AML. This supports the notion of uncontrolled polycythemia vera and the rationale to switch therapy in this subset of patients. In addition, a recent retrospective analysis of practice patterns with hydroxyurea among clinicians treating PV in the US suggests that a significant subset of patients continue to experience suboptimal control of their PV, as characterized by persistent elevations in their blood cell counts and the continued presence of disease-related symptoms. Here we have the ELN criteria for hydroxyurea resistance or intolerance. As one can see, the need for continued phlebotomies after 3 months of at least 2 grams per day of hydroxyurea is one measure of resistance. Uncontrolled myeloproliferation after 3 months of at least 2 grams per day is another measure of resistance. Continued splenomegaly after 3 months of at least 2 grams per day is an additional measure of resistance. The emergence of cytopenias at the lowest dose of hydroxyurea required to achieve CR or PR is also considered resistance, and by some investigators, it's considered intolerance. The acquisition of non-hematologic toxicity, such as mucositis, depression or fatigue, or any other issue related to the drug, is considered intolerance of hydroxyurea. As I mentioned earlier, the JAK2 inhibitor Ruxolitinib is approved for use in patients with polycythemia vera who do not respond to or are unable to tolerate hydroxyurea. Typically, the recommended starting dose is 10 milligrams twice daily, but dose adjustments based on count monitoring should be considered as appropriate. And as we will see in the next segment, sometimes the starting dose may need to be adjusted. Adverse events with Ruxolitinib have been well characterized and usually include cytopenias, which can be managed via dose modifications, as well as non-hematologic events such as dizziness and headache. What about some of the evidence that supports the use of ruxolitinib in treatment-refractory polycythemia vera? In the phase 3 response study, which tested ruxolitinib versus best available therapy, ruxolitinib was superior to standard therapy in achieving hematocrit control and spleen volume reduction of 35% or greater, 28.9% in the study arm versus 0.9% in the control arm, with a p-value of less than 0.001. Hematologic complete response was also significantly improved with ruxolitinib versus standard therapy at 23.6% versus 8.9%, with a statistically significant p-value of 0.003. Longer-term follow-up at 80 weeks continues to show the durability of hematocrit control on ruxolitinib therapy among responders, and the responses have continued over time. Although the trial was not designed to evaluate meaningful differences in rates of thrombosis between the two arms, there was a numerically higher rate in the BAT arm compared to ruxolitinib, suggesting, at a minimum, no increased risk of thrombosis, which is reassuring as this is a major focus of therapeutic intervention. In addition, compared with standard therapy, ruxolitinib substantially controlled a multitude of PV-related symptoms in hydroxyurea-resistant or hydroxyurea-intolerant patients and improved ratings for quality of life and various functional subscales, like the emotional, social, and physical scales, when compared with the BAT treatment arm. Now, there was another study, the Response 2 study, which mirrored the design of Response, but in patients without splenomegaly. The findings in this trial favored the ruxolitinib arm and were similar results in terms of controlling hematocrit and overall control of the CBC and symptoms. In other words, the presence of splenomegaly for success in therapy of patients in second line with Rux treatment is not a prerequisite based on the Response 2 trial. What about other aspects of disease control with Rux? On this slide, you can see an exploratory analysis from the Response study looking at control of the white blood cell count with ruxolitinib compared to best available therapy and also compared to hydroxyurea, specifically as a best available therapy. You can see that patients treated with ruxolitinib had a rapid and deeper reduction in their leukocyte count when compared to either the whole group of best available therapies or indeed to hydroxyurea alone. This may be an important aspect of disease control for patients with PV and particularly valuable effect of JAK2 inhibition, although it does require validation in further studies. In summary, we've seen that PV can be a clinically challenging disorder, one that is associated with symptoms that, although manageable, can persist and worsen over time. The goals of therapy include the prevention of potentially serious thrombotic events and the delay of disease transformation. We do have therapies that help us achieve these goals, including phlebotomy, cytoreduction, either with hydroxyurea or interferon alpha, and the JAK2 inhibitor ruxolitinib. It's also important to be aware of the potential for uncontrolled disease, which describes a scenario where phlebotomy alone is no longer adequate to control blood counts or symptoms, and more aggressive therapy is needed. Stay tuned for the next segment of this activity, when I welcome a patient with PV and discuss her thoughts on many of the topics and themes we've covered. Welcome back. In this segment of the program, we're going to hear from a patient with polycythemia vera and consider how her experience highlights some of the issues we've already discussed. It's my pleasure to welcome Joanne Menino to the panel. Welcome, Joanne.
Thank you, Dr. Mascarenhas. It's nice to be here.
Joanne, why don't you begin by telling us a little bit about yourself and what your life was like when you were first diagnosed with PV?
I'd be happy to. I'm a longtime resident of Brooklyn Heights in New York City, and I was diagnosed with polycythemia vera about 17 years ago. I was in my early 30s. I had a very active lifestyle. I was running, training for my first marathon at the time, and I began to experience some symptoms that later turned out to be PV.
And what were those symptoms?
Mostly, and it was headaches. very severe, sometimes migraines, but mostly just really bad headaches. At times I had spontaneous gastrointestinal bleeding. And at the time, my doctors diagnosed me with PMS. It was when I was trying to donate blood at a blood drive, and I was rejected because my hemoglobin was too high, that I finally addressed this with my doctors. I had a CBC and was able to actually go back and find previous records and found that I had hematocrit in the 60s for well over several years.
So Joanne, the rarity of polycythemia vera often makes it challenging for colleagues in the field to pick up the diagnosis at onset. A history of headaches or other symptoms frequently precede the actual establishment of diagnosis of polycythemia vera, and it's only when patients and their physicians go back and look at their hematocrit that they see that it was potentially elevated for quite some time. So the story you're telling actually is quite common. It's one that I see frequently. Now, how did your experience change once you were referred to a hematologist?
Well, first I started doing my own research, and I realized how serious the situation was. I began to understand what the symptoms meant and what the different blood counts and the elevated blood counts meant. The hematologist at the time was not an MPN specialist, but he did treat other MPN patients. So I felt confident in staying with him. His diagnosis of the PV and the symptoms that I was having led us both to decide that phlebotomy was the only necessary treatment at the time. And once I was phlebotomized and my hematocrit was back down to the normal level below 43, my symptoms resolved and I was able to resume my active lifestyle.
So Joanne, talk to us a little bit about your experience with long-term therapeutic phlebotomy and your experience of changing caregivers during your therapy.
So I lived for many years on phlebotomy alone, and I was doing very well. My symptoms were non-existent for the most part.
So the headaches, for example, went away.
Headaches went away. I never really had pruritus or night sweats. I would say that I was fatigued in comparison to my peers, but compared to a polycythemia vera patient or an MPN patient, I didn't have fatigue. I was running marathons.
So you were still running the
time.
marathons?
Yeah. I was a good patient. I saw my hematologist every 3 months, and we phlebotomized when necessary, but other than that, I was doing really well.
And were you taking concurrent aspirin with the phlebotomy?
At the time, I was not. I take a lot of vitamins that also had sort of anticoagulant properties, so I felt okay doing what I was doing. But after a few years, my hematologist retired, and his patients were taken over by another doctor who was also a good doctor, but he and I never really clicked. And at the time, I was active with the MPN Research Foundation, and a friend there told me that Dr. Hoffman was moving from Chicago to New York, and I had seen Dr. Hoffman at various patient conferences, so I knew he was somebody that I could work with, and so I switched my care to Mount Sinai.
So Joanne, tell me how interacting with the MPN patient support groups helped you make decisions or come to terms with your disease and your therapy.
So there are a number of different groups out there, and one of the groups that I'm with has a number of patient experts, I would call them, who offer both scientific and emotional support for people who are unsure. Some people aren't in a major city where they can get expert care, and so it's great to use those support groups to find information and get doctor recommendations.
Yeah, that's a very good point, Joanne. We often find in our practice that patients find value in patient support groups in either identifying symptoms or raising awareness of clinical trial and other options that may be available to patients. And this can be very rewarding or helpful to patients when participating in these groups. Okay, so Joanne, let's move on and talk about more of your recent experiences. It sounded like you had very good control of your disease and your symptoms for many years with phlebotomy alone, but then you began to have more significant symptoms and needed to switch therapy.
Yes, it definitely was a big contrast. So for 13 years, I was on phlebotomy alone. And like I said, I really didn't have any issues. But then I started to have symptoms that turned out to be pulmonary hypertension, along with pericarditis. And then most recently, I've been diagnosed with an immune disorder. So initially, I stopped running after about 13 years, and that was due to a hip impingement. And then, I started to have these symptoms of pulmonary hypertension, and at the point where I stopped running, suddenly my phlebotomy needs started increasing, and I was initially, for the first 13 years, phlebotomizing about once a year or once every 9 months. And after I stopped running, it started to be every 3 months. And then last year I had surgery for endometrial cancer. I had a hysterectomy, and after the surgery, my spleen became irritated. After about 2 months, that hadn't resolved, and we did a CT scan. And I knew that my spleen was enlarged, but it also turned out that my liver was enlarged, and I became more concerned about what that meant. And I also had an echocardiogram at the time, and the pericarditis had actually gotten a little bit worse. So at that point, Dr. Kremenskaya, who's my current physician, decided that drug therapy was indicated. And at that point, I knew it was the right decision for me.
Now, did you research drug options on your own when your symptoms worsened? As many of the viewers know, first-line options for cytoreductive therapy include drugs like hydroxyurea and interferon, which we've spoken about. What was the process in making the therapeutic decision-making in your case?
Well, over the many years with the disease, like I said, I was active within my community. I knew patients who were taking interferon. I knew patients who were taking hydroxyurea. I initially, when I was younger, and I had the luxury of being anti-drug, and I knew, at that point I didn't need it.
Right, because you were doing well on phlebotomy.
I was doing well. And my research, understanding some of the side effects of hydroxyurea, skin toxicity, and potential to convert to leukemia. I was very concerned about taking hydroxyurea. Also, with interferon, I was concerned about potential depression because I live alone and I don't have anybody to, notice if my behavior started to change.
So those are really good points. So you were, obviously you're someone who has been involved in self-education and reading about the disease and the therapies, so you were already aware of the potential toxicities, and likely that colored your willingness to want to be on a therapy based on the potential toxicity profile. But also, it sounds like you were doing quite well and still maintaining an active lifestyle on phlebotomy, and perhaps didn't quite need cytoreduction. So the discussion you have with your doctor brings up I think a very interesting and important point, that it's really it's key for patients and physicians to work as a team when developing a therapeutic strategy that's tailored for that specific patient and their specific scenario, and not a generalized treatment approach. It really becomes a personalized therapeutic decision making.
I would agree. We decided on hydroxyurea, and we started at a dose of 500 milligrams. And after about 6 weeks, there wasn't much change, so we upped the dosage to 1 gram.
And much change in your blood counts or your symptoms, or?
In my blood counts and in my symptoms, both.
Okay.
And then about 8 weeks after we started at 1 gram, my blood counts showed a severe cytopenia. So
okay.
At that point, Dr. Kremenskaya recommended that I go on Ruxolitinib.
And just can you frame that conversation? You were coming into the office, your blood counts were now lower than they should be, and was the consideration to switch therapy something that was prompted by you, by your physician? Was it a mutual discussion? How did it evolve?
We were monitoring me, and I had the cytopenia. I was also having mouth sores, and Dr. Kremyanskaya just felt that I would be doing better on ruxolitinib.
So it sounds like you met the definition by ELN of actually both resistance and intolerance, which can occur in about 15 to 20% of patients with on hydroxyurea therapy, and is often the reason why there's a discussion and consideration for switch in therapy now either to ruxolitinib or historically often to interferon alpha or other cytoreductive therapies.
So at that point, I started on ruxolitinib at 10 milligrams twice a day, and it worked quickly to reduce my spleen, and my counts seemed to be under control.
And Joanne, when you say quickly, did it work in days or like weeks? What was the time frame?
Yeah, it was sort of days. Definitely within 2 weeks, I couldn't feel my spleen anymore.
That's fantastic.
And then, my counts rebounded, and I was doing well. But after about several months, I started to experience the symptoms, which now are, the autoimmune disorder. So I was having foot pain and knee pain, and also I gained about 20 pounds. Which was not welcome. Yeah. And so in late March, I decided that I wanted to at least interrupt ruxolitinib. And when I came off of it, I started to have rebound effects pretty quickly.
Rebound in your symptoms?
In my symptoms, I did get pruritus. I had a cognitive disability. I was really having a hard time concentrating.
Okay.
I was exhausted. But the foot pain and the knee pain got worse. And so at that point, we decided to go back on ruxolitinib, but at a reduced dose.
Okay.
So I went back on at 5 milligrams twice a day.
Okay. I mean, you've brought up two important points that should be highlighted. One of them is autoimmune diseases are actually quite prevalent in patients who have myeloproliferative neoplasms. And sometimes they respond to therapies, sometimes they don't, sometimes they can be exacerbated by therapies. Unusually, ruxolitinib is actually a drug that is used in autoimmune diseases too, and sometimes it can actually be effective in addressing some of the autoimmune manifestations as well. But you also brought up an important point too, that ruxolitinib can work quickly, but sometimes when stopped, people can have rebound of the symptoms, which can be quite unpleasant. And I've even seen patients get symptoms that are related to the disease that they may not even have actually had previous to the drug that can become bothersome. So it's not unusual that people will then end up going back on the ruxolitinib, just kind of exactly the way you described.
Yep.
Oh, and I will point out, the weight gain that you described is also a consequence of the ruxolitinib, which I'm sure you're aware of. Oddly enough, we as hematologists that treat MPNs look at weight loss as a negative or a disease-related consequence that's a problem, and that gaining back weight is a good thing. The issue often is, for some patients, that weight gain can go beyond their normal weight and can actually lead to being, in some cases, overweight. And that can be, particularly for someone like yourself who's an athlete and a runner, that can be disturbing and frustrating. So Joanne, the experience you had with the need for dose hold and dose modification is not uncommon and can occur during the treatment of patients with polycythemia vera and other related diseases with ruxolitinib and other tyrosine kinase inhibitors. Thankfully, there's an FDA label that guides physicians on how to stop the drug and how to restart the drug in terms of platelet counts and hemoglobin levels with dose modifications. So the dose of the drug is really based on the starting platelet count, but many physicians in the field, myself included, will often start at a low dose and titrate up slowly, although that's not exactly the way the label is written. This is in my opinion, this is a common phenomena that we see in tyrosine kinase inhibitors that get approved based on clinical trial data, whereas once there's more experience with the drug, often people who prescribe it a lot will prescribe sort of off-label in the sense of lower doses and titrating up, as well as the need for understanding when to hold the drug and dose reduce or restart therapy based on emerging cytopenias. Now, Joanne, is there anything else you want to add about practical issues related to being on therapy with a JAK inhibitor?
Yeah, so initially taking the medication was a little bit difficult. It's twice a day therapy, and I take other pills, or other vitamins, et cetera, in the morning, so that was easy to incorporate. But the evening dose, trying to take it 12 hours later became a little bit difficult. So eventually I needed to get an AM/PM pill box, and I use an alarm on my phone to remind me to take the pills at the same time.
So as a physician, I used to always find it sort of unbelievable to me that patients had trouble taking PM doses until I became a patient and realized it's actually very easy to forget taking PM doses. So I've learned that lesson as well. And the use of pill boxes for a lot of patients, even young patients who sort of look at it as an old patient kind of thing, can actually be very helpful to keep compliant. Now, I understand that you've also been adding cytoreduction therapy with hydroxyurea back into your treatment regimen. Can you talk to us about that?
Yeah, so I continue to do research, and because I have pulmonary hypertension, I've done a lot of cross-referencing of the two diseases, and so what I found is that the same types of progenitor cells in MPNs are also implicated in pulmonary hypertension. So it was important to me to address that. I found a study that was on pulmonology side that was going to administer hydroxyurea to those patients to see if they could change the course of the pulmonary hypertension. And so, I was eager to do a combination of ruxolitinib and hydroxyurea to see if that could help me.
Unfortunately, pulmonary artery hypertension is not an infrequent complication of MPNs, and probably occurs in about a third of patients who have MPNs over time, and can be debilitating the way you've described, with difficulty getting upstairs and limiting activity. So drugs like ruxolitinib or hydroxyurea, and in your case, sounds like the combination, can sometimes be employed to try to address that additional complaint. So you've certainly had an interesting experience with polycythemia vera. Are there any final thoughts you'd like to share with the viewers?
Yeah, I mean, it's been a rough course. It didn't impair me at all for 13 years, and now the past 4 or 5 years have been a little bit more difficult. It's definitely a bigger burden, and I feel in uncharted waters in terms of the comorbidities that I've been accruing. But I think I feel really confident in the care that I'm getting and in my ability to advocate for myself with my doctor, which I think is extremely important. And so I continue to educate myself and stay abreast of everything that's happening in this field.
So Joanne, thanks very much for being here and participating in this discussion today.
Thank you, John. It was a pleasure.
And thank you for joining us as well. I think that we've seen through Joanne's story not only how PV can evolve over time, but also how diagnosis and treatment can be challenging and more complex than many of us might think. Thankfully, we have options available for patients from phlebotomy and low-risk disease to cytoreduction and JAK inhibition in more aggressive settings. Thanks again for joining us, and have a good day.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/MBS. This activity is supported by an educational grant from Insight Corporation.